If you walk into any emergency department right now, you're witnessing what looks like chaos.
Yeah.
But it's not. It's
Yeah.
it's structured intensity.
Exactly. It feels fast, it feels chaotic, but every single person, every single decision is governed by protocol.
The kind of operational blueprint, right?
Yeah.
Designed to just conquer the intensity and save lives.
And that blueprint is what we're tearing apart today. Our source material is the gold standard for many practitioners. Key excerpts from the Oxford Handbook of Emergency Medicine.
So our mission is to stop looking at the symptoms for a minute and start looking at the system itself.
Right. We want to uncover the non-negotiable rules, the triage secrets, and the critical protocols that turn a crisis into, well, structured action.
You know, what immediately jumped out at me from this handbook is that the rules aren't just for the patients, they're for the people doing the saving. It's a job defined by extreme pressure, and the handbook actually recognizes that. There are formal guidelines about staff taking breaks, refusing to work through illness.
And even, I think it says, if you feel yourself getting angry or frustrated, you have to take a quick breather, a deep breath.
It speaks volumes, doesn't it? It's acknowledging that human error is so often linked to exhaustion and just overload.
The first rule is effectively manage yourself so you can manage the crisis.
And that focus on managing intensity brings us right to the operational core of the ED triage. This isn't just about putting people in a line.
No, not at all. It's a high-speed, high-stakes system of sorting severity. Its whole purpose is to make sure the most life-threatening conditions get seen first.
And the clock starts ticking immediately.
Instantly. The Royal College of Emergency Medicine guidelines are so clear on this. You should wait less than 15 minutes to be triaged, and the assessment itself should only take a few minutes.
If it takes longer, you're holding things up.
You're holding up life-saving resources.
Exactly.
And that rapid assessment is tied to this incredibly strict timeline, often this color-coded scale. Could you walk us through those tiers? Because they really dictate the entire flow of the building. They're completely non-negotiable windows. Our red patient needs immediate attention. There is no delay.
Zero.
An orange patient is very urgent. They must be seen by a clinician within, say, 5 to 10 minutes. Yellow is urgent within an hour.
Okay.
Then you move down to green, which is standard care, within 2 hours. And finally, blue, non-urgent, up to 4 hours. So you can see how just one red patient immediately changes that whole board.
That system is all about speed. But speed can sometimes clash with a fundamental aspect of human dignity. And that leads to one of the most powerful mandates in this handbook, the analgesia mandate.
This is a huge one. The directive is crystal clear, totally uncompromising, never delay pain relief to allow for further examination.
The patient doesn't have to earn it.
They do not have to earn analgesia. It's a right.
And the document is surprisingly strong on this.
Yeah.
It explicitly calls the old concern about pain relief masking signs, like in an acute abdomen case. It calls that idea inhumane and incorrect.
It is, because that concept of masking signs is often a myth. And even if pain medication did subtly alter a physical sign, delaying relief for hours while you're waiting for a scan or labs is it's an unacceptable trade-off.
We have better diagnostics now.
We have incredible diagnostics. Pain is a vital sign. Managing it builds trust. It reduces the patient's physiological stress response, which can actually complicate things anyway. It's an immediate priority.
So once the patient is triaged, stabilized, and pain is managed, the discipline shifts to communication. In the ED, every minute you spend writing is a minute not spent treating.
Right, so it demands precision, focus. Documentation in the ED has to be centered on the immediate priorities, the key issues from the first few hours.
And you leave the long, detailed story for the ward team.
Exactly. The comprehensive clerking is for when the patient is admitted and stable.
And that precision is absolutely vital when referring a patient out of the ED. What's the protocol for that handover?
It's like a formalized script, and it's designed to minimize error. You introduce yourself, you summarize the patient history, investigations, treatments so far, and then you clearly state your objective.
The ask.
The ask. Am I asking for admission, or am I just seeking a specialist opinion? And the rule is, if that team declines to admit, the ED staff must immediately escalate to their own senior staff. You don't just hang up.
Right. Okay. Shifting to safety fundamentals. This is where the handbook gets really meticulous. We all know about hand hygiene. But what about the specifics of PPE?
The rules are all driven by risk. For basic contact, you use disposable gloves. Nitrile gloves are specifically required for anyone with a latex allergy, but for high-risk, airborne threats, like with SARS or COVID-19.
That's when the FFP3 comes out.
That's when the FFP3 respirator is specified. It filters those tiny aerosolized particles. It's not just a surgical mask.
And probably the most non-negotiable rule of all, Sharp's discipline.
Never, under any circumstances, resheath a used needle.
Because that's the highest risk for a needle stick injury.
Right. It is the single highest risk. It's an act that happens under pressure, often one-handed, and it's just asking for an accidental self-inoculation. The rule is simple. Use it, engage the safety, and drop it straight in the Sharps container. No hesitation.
Okay, moving from general rules to individual needs, the handbook highlights specific patient groups that require added needs. I mean, obviously every patient needs the best care, but these groups pose unique challenges.
We're talking about patients like the elderly, who often present with multiple complex issues, social and medical. If an elderly person falls, the book urges staff to avoid the diagnosis mechanical fall.
Why is mechanical fall such a red flag term?
Because it implies the fall was just an external trip. It suggests it wasn't a symptom of an underlying medical problem like a cardiac arrhythmia, sepsis, or a neurological event.
So it shuts down the investigation too early.
It closes the door. The job is to find the medical reason why they fell.
That makes perfect sense. And what about patients with learning difficulties? The handbook notes they might have a higher pain threshold.
Yes, and their tolerance for pain can lead to a really delayed presentation. They're often much, much sicker by the time they arrive.
So the common thread for all these groups, the elderly, those with learning difficulties or language barriers, is communication.
Communication is everything. It becomes a form of critical care. If you can't communicate, you can't get a baseline status, and you can't assess for deterioration.
And speaking of baseline status, staff rely on standardized checkpoints.
Yeah.
The new WS2, the National Early Warning Score, is the standard tool.
It gives everyone on the team a common language for a patient's vital signs. The handbook also provides these crucial quick reference data points for blood tests, like an arterial blood gas, an ABG.
And when you look at those ABG ranges, the tolerances are they're astonishing. You list a healthy pH range of 7.35 to 7.45. What does it mean if a patient drifts outside that tiny band?
It means they are in massive metabolic failure. The body operates on a razor's edge. That 0.1 range it's the difference between life and death. If you drop below 7.35, you're in acidosis. If you go above 7.45, alkalosis. Either way, every enzymatic process in your body starts to fail. Knowing those little numbers gives the physician an instant frame of reference for how critically ill someone is.
I love that they also include these little conversion nuggets, like how to quickly get from Fahrenheit to Celsius. They're trying to eliminate any friction during a critical moment.
Exactly. And it's the same idea with vascular access, getting a central line in. There are strict protocols.
So where's the preferred spot for rapid central access?
In general, the internal jugular vein in the neck is preferred over the subclavian approach. The reason is all about risk mitigation.
You want to avoid a complication.
You absolutely want to avoid causing a pneumothorax, a collapsed lung, which is a higher risk with the subclavian site. The last thing you want to do is create a new problem.
But what if there's severe trauma, burns, something that makes the neck or chest inaccessible?
In those cases, the femoral vein in the groin is a really useful site for temporary access. And no matter the location, the Seldinger technique is specified as the method of choice.
Which, if I remember, uses a smaller needle and a guide wire, rather than trying to force a large catheter straight in.
Precisely. It's a technique designed for precision, even in chaos.
Okay, let's turn to the protocols for true time-as-everything emergencies, starting with sepsis. This is the definition of a time-sensitive killer.
It is. Identifying it fast is paramount, and the ED relies on quick criteria called QSOFA.
What does that look for?
It's a simple screening tool, just 3 signs. A respiratory rate of 22 or higher, a systolic blood pressure of 100 or lower, or an altered mental state.
And if a patient hits 2 or 3 of those?
They're immediately flagged as having an increased risk of mortality, and it triggers a specific response, the Sepsis 6 Care Bundle. And this entire bundle has to be delivered within 1 hour.
That is an incredibly tight deadline. What are those 6 mandatory actions?
Okay, they are: give high-flow oxygen, take blood cultures, give immediate IV fluids, start FAVI antibiotics, measure blood lactate, and monitor urine output.
Every single one is aimed at stabilizing the patient while attacking the infection.
Right. And that blood lactate measurement is so important.
Why that one specifically?
Lactate tells you about tissue perfusion. High lactate means the patient is in shock, even if their blood pressure looks okay for a minute. If that initial level is 2 millimol or higher, you have to repeat it within 2 hours.
to see if what you're doing is working.
It's the only way to track if your resuscitation is actually saving their organs.
Moving to cardiac arrest, the timing for drugs is incredibly precise. When do you give that first dose of adrenaline?
It depends entirely on the rhythm. In shockable rhythms, VF or VT, you prioritize electricity. You give adrenaline only after 3 shocks have failed.
But for a flat line,
But in non-shockable rhythms, like asystole or PEA, there's no electricity to fix. So you give adrenaline as soon as you possibly can to try and chemically kickstart the heart.
the sources mention something that sounds almost primal. External cardiac percussion. Hitting the chest.
It's a dramatic measure for a very specific situation. An extreme, life-threateningly slow heartbeat, a bradyarrhythmia, and there's a delay in getting the pacing equipment ready.
So it's literally to buy time.
You are literally trying to stimulate a few beats of cardiac output to buy time. It's a last resort when minutes count.
For a polytrauma victim, maybe from a car crash, the response has to be standardized. This is where ATLS comes in.
Advanced Trauma Life Support. It's a cognitive framework, a repeatable system to manage multiple simultaneous injuries. The #1 goal is to prevent the triad of death.
That sounds ominous. What is the triad of death?
It's a vicious cycle that kills trauma patients. It's trauma-induced coagulopathy, so the inability to clot.
Right.
Acidosis from poor perfusion and hypothermia. These 3 things feed each other and make the patient almost impossible to save if you don't break that cycle immediately.
And the primary survey to prevent this is the famous CABCD approach. Break down that sequence for us.
It is a strict prioritization.
Yeah.
C is for catastrophic hemorrhage. If they're bleeding out, you stop that first before anything else.
Before even airway.
Before airway. Then A is airway with C spine control. B is breathing. C is circulation. D is disability, a quick neuro check. And finally, E, exposure, getting all their clothes off to look for hidden injuries.
It's a rigid flow. Now, specifically for kids, the sources highlight a risk called SC-WARA.
Spinal cord injury without radiological abnormality. It's a unique risk for children because their spine is so much more elastic than an adult's.
So it can stretch and snap back.
Exactly. And that momentary displacement can injure the spinal cord, paralyze the child, without actually fracturing the bones that you would see on an X-ray. It's a diagnostic trap.
Terrifying. Let's look at 2 specific toxicology emergencies, starting with paracetamol. What's the critical time component there?
The 4-hour window. If a patient overdoses, you have to take blood tests at or after the 4-hour mark to accurately assess their risk of liver damage against a special graph.
And if you can't get those results in time?
If the levels aren't available by 8 hours and you have a high suspicion of a toxic dose, you have to start the IV antidote, acetylcysteine, immediately. You cannot wait. You're running out of time to save the liver.
And with carbon monoxide, or CO, poisoning, the thing is cherry red coloring is rarely seen in live patients. What are the warning signs?
The danger is that the early features perfectly mimic a viral illness. Headache, nausea, vomiting. If multiple people from the same house present with those vague symptoms, the alarm bells for CO should be ringing.
And the treatment?
It's simple but powerful.
Oh.
Oxygen. Breathing 100% O2 cuts the elimination half-life of CO from over 5 hours down to just 80 minutes.
Wow, a 4-fold increase.
That speed is life-saving.
That precision continues when dealing with truly high-risk scenarios like blast injuries. This isn't just about shrapnel wounds, is it?
Not at all. It's about understanding the physics of the explosion. The handbook breaks it into 4 mechanisms. The primary injury is from the pressure wave itself.
What did that do?
It causes damage at air tissue interfaces, so ruptured eardrums or the really dangerous blast lung.
So I know to check the lungs even if they look fine on the outside.
Exactly. Secondary injury is from flying debris, so penetrating trauma. Tertiary is the person being thrown by the blast. And quaternary is everything else burns, smoke inhalation. The mechanism tells you what invisible damage to look for.
Another subtle high-stakes area is managing patients who are already on anticoagulants, who then come in with a bleed.
Right, and you have to know the specifics. Warfarin, for instance, can actually make you more likely to clot when you first start it before it settles into its therapeutic range.
So who gets instantly put in the high-risk box for a severe bleed?
Anyone with a recent major bleed, anyone on dual antiplatelet therapy, patients with renal impairment, and critically, anyone with a low platelet count. If they tick any of those boxes, the protocol shifts immediately to reversal agents.
Now, at the intersection of toxicology and law, you have body packers, people who swallowed drug packages.
And if those packages leak, It's a massive life or death poisoning. But treating them has this huge legal complexity. In England and Wales, you can't just order a scan to look for drugs.
You can't.
No. It requires the patient's explicit written consent and formal authorization from a police inspector. It's a huge challenge, balancing a clinical emergency against really strict legal requirements.
And the final, unavoidable protocol for the ED staff is dealing with death.
The initial steps are logistical, but so critical. Reporting suspicious deaths to the police or coroner, informing the next of kin, notifying the GP, canceling all their appointments.
The guide also emphasizes something that can get overlooked in the rush: organ donation potential.
It does. Many patients who have an unexpected cardiac arrest and can't be resuscitated are potential donors of corneal tissue and heart valves. Recognizing and flagging that is a crucial final step.
We've uncovered this incredible blueprint here, from the philosophy of pain relief to the 5 colors of triage, all the way to the physics of blast injuries. It shows that mastery is really about operating within a rigid structure while facing absolute chaos.
And that structure is what allows for quick adaptation. I mean, think about pediatrics. Drug dosing is all about weight. If you can't get a weight, you use a formula, like age in years plus 4 divided by 2.
But that's just a starting point.
It's just the starting point. The real lesson in this handbook is the need for continuous vigilance, for adapting your diagnosis as the picture changes.
It all comes down to trust, in a way.
Yeah.
Handbook says you have to treat every patient on their merits, even if a referral seems inappropriate at first.
Because the information the referring clinician has is often so different from what you see in that first minute in the ED.
That's the key takeaway.
It is. The ED staff has to operate on the assumption that their knowledge is incomplete. So think about this. When a patient is rushed in, what essential piece of non-obvious social history or chronic long-term symptom might the referring GP know that the ED team might miss in that high-speed CABCD survey? The most critical knowledge is often the knowledge you don't yet have. That's why the vigilance can never, ever stop.